Well, epilepsy is a disorder in which you have seizures, and seizures occur due to abnormal firing of the nerve cells of the brain. Your brain is made up of a whole lot of nerve cells or neurons, and they fire abnormally, and they have this synchronized activity which causes a seizure. And when you have epilepsy, you are prone to having recurrent seizures. Epilepsy is a group of disorders, and we tend to think of them now as the epilepsies. There are many types of seizures and many different epilepsy syndromes, and there are also many causes. So you can have patients who have epilepsy who may just have staring spells where they're not with it, and then you may have patients with epilepsy who fall to the ground and convulse, which is what most people think of when they talk about epilepsy. So it comes in many different shapes and sizes. So the epilepsies comprise many different types of seizures, but they fall into two main groups. The first are the focal epilepsies and the second generalised epilepsies, and these are the epilepsies that people know most about. So with a focal seizure, the seizure begins in one part of the brain or may spread to involve both sides of the brain. And focal seizures are often quite bland and boring. People might just stop and stare. They may have some head and eye deviation. They may not respond. They may have some mouthing. Oral automatisms, may have some hand involvement. And then this may last 30 seconds to a few minutes, and then they'll come around and they'll be a little bit confused and perhaps drowsy, maybe have a headache. So that's the common form of focal dyscognitive seizure. That's the new terminology. The old terminology for that is complex partial seizure, and a lot more people will be au fait with the term complex partial. But nowadays we say focal dyscognitive. Focal from one part of the brain. Dyscognitive means altered cognitive cognition, so altered thinking, altered awareness. So you call it focal dyscognitive or a focal seizure with altered awareness. With the focal dyscognitive seizure, it can spread to involve bilateral networks of the brain, both sides, and then the person may go on to have a convulsion. So they may have the staring part of a seizure and then fall to the ground, go stiff all over, jerking and unconscious. And that's really frightening to see. And people often think someone's dying when they see someone for the first time. They may sometimes bite their tongue or be incontinent, but that doesn't tell you anything about the seizure. It just suggests that they've probably had a convulsive seizure. So the second major group are the generalised epilepsies, and there are multiple different types of seizures in the generalised epilepsies. Usually in the generalised epilepsies, you do not have an aura because the seizure discharge involves both sides of the brain at once. So you lose awareness and you don't have that moment of feeling the seizure coming on. The generalised epilepsies can be the convulsion that we talked about, where you go stiff and jerking all over, you fall to the ground, you're unconscious. Often you can hurt yourself, and they can last just a minute or two, or they can be more prolonged. You can also have generalised seizures where you just have a staring spell, and this is called an absence seizure. In the past, it used to be called petit mal, but we don't use that terminology anymore. An absence seizure is brief. It often lasts somewhere between 2 and 20 seconds, and the person may just have loss of facial expression, or they may have some eyelid fluttering, or they may have some mouthing. And then when the seizure finishes, they're back with it usually. They may just have forgotten that moment or two, but they're not tired. Quite different to the focal dyscognitive seizure. The other important type of generalised seizure is the myoclonic jerk, and that's just a very sudden jerk, faster than I can fake actually, and it involves often the whole body, but it can just be one arm or one leg, and they occur awake, and they're called myoclonic seizures. And then the last group are the drop attacks, and you can have many different types of drop attacks. You can have tonic seizures where you go stiff. You can have atonic seizures where you crash to the ground, you crumple, and you can even have myoclonic or jerk seizures that can cause you to fall to the ground. So that's sort of an overview of all the seizure types. Well, epilepsy can begin at any age. There are two peaks, one at the beginning of life and one at the end of life. So 80% of epilepsy begins in infants, children and adolescents, which is why I'm a child neurologist, and it's really the most common disorder that I see. Epilepsy has a huge range of causes, and many people accept that if you have a bad head injury, such as in a car accident and you're knocked unconscious and you're in intensive care and you sustain brain damage, many people accept that that will cause seizures. But you can also have a very normal brain on imaging and have seizures due to other causes. These causes can be metabolic problems that can arise elsewhere in the body, so for example, an abnormality of sodium or calcium metabolism, or they could be due to an infection, particularly in developing countries. There are infections that can commonly cause seizures, like neurocysticercosis in India, very common cause of focal epilepsy. So here there's an important distinction between having a seizure and having epilepsy.
Yes.
So if you have diabetes and your blood sugar goes too high or it goes too low, that can certainly put you at risk of having a seizure, but that is not epilepsy. That is just an epileptic seizure, but it is not having the condition of epilepsy. It's an event caused by a metabolic abnormality, and we don't generally think of that as epilepsy. Epilepsy is where you have an ongoing predisposition to seizures, so to recurrent seizures. Also in the focal seizures, one has to remember that patients often have an aura, and an aura is the same as a warning, and it represents a focal discharge beginning in one part of the brain. Now, one of the best known auras is déjà vu. It's important to know that déjà vu is common and normal. We all have it, but when we have it in a normal setting, it's often very brief, and by the time you recognise you're experiencing déjà vu and you want to hold on to that feeling, it's gone. On the other hand, if you have epileptic déjà vu, it's often intense, unpleasant, and you can't just turn it off. It keeps going for maybe 10 or 20 seconds. So déjà vu is one aura, but there are many other types of auras. You can have tingling or pins and needles in a part of your body. You can have a strange sensation in your tummy or in your head. You can have other sorts of hallucinations, such as visual hallucinations, smell and taste. So these are different types of focal seizures or auras with retained awareness. They can then spread to involve parts of the brain which lead to altered awareness, so you have a focal dyscognitive seizure, and then this can spread to a major convulsion where you have bilateral involvement, both sides of the brain. As a doctor, it's very important to establish a diagnosis of epilepsy, and this is not based on the EEG or the MRI, it is based on a history of the events. So you cannot have epilepsy unless you have seizures, and those seizures have to be very clear events that happen out of the blue and clearly described. So when you want to look into a history of epilepsy, you need an eyewitness account. Not just the patient's experience, because they often don't know what's happened, but you need to speak to the person who saw the patient have the seizure and get a history of recurrent events that are seizures. The EEG is important because it provides supporting evidence for your diagnosis of epilepsy. But many patients have epilepsy and never have an abnormal EEG, so it really hangs on the description of the events. Also, the MRI, which looks at the structure of the brain, gives supporting evidence. If it's normal, it's not particularly helpful. It's reassuring, but it's not particularly helpful. If it's abnormal, that may help support the diagnosis of epilepsy. So the most important thing is that epilepsy is a clinical diagnosis made by your doctor. My role as a doctor is really multi-pronged. The first one is to figure out if the patient really has epilepsy and determine the nature of their epilepsy diagnosis. And from that point of view, I try to determine their exact epilepsy syndrome. This is not always possible, but I can manage to do it in probably about 80% of the patients I see with epilepsy, their specific epilepsy syndrome. The next part of my role is to determine the appropriate management. Does the patient need medication, or have they maybe just had 1 or 2 seizures and you're going to wait and see if further seizures occur before you give medication? If they need medication, which is the best medication, how are we going to monitor that? Even if they do or do not have medication, we have to think about the psychosocial consequences of their epilepsy. How's it going to affect their day-to-day function? If it's a child, Their teachers need to know, the school needs to know, they need to know what they're looking out for. If it's an adult, are they going to be able to work? Their work colleagues probably need to know what might happen so that they can recognise a seizure. Importantly for adults is, will they be able to drive? And often they cannot drive until the epilepsy is sorted out and well controlled. And there are legal requirements about when you're allowed to drive once you've had a seizure, and your doctor will be able to help you with that. There are also other aspects of my role. One is supporting the patient and their family with coming to terms with the diagnosis, what it means for the patient and the family. What's the long-term outlook? Is the patient likely to be fully controlled with medication? Will they grow out of their epilepsy? All of these are critical issues, and so the role of the doctor is not just diagnosis, but also taking the patient and their family on the journey to make sure they have the best possible management. When you start anti-epileptic medication for a patient, 70% of patients can be controlled on one anti-epileptic medication. The remaining 30% may require more than one medication, and sometimes they require 2, 3, 4 medications depending on how responsive their epilepsy is to the different anti-epileptic medication. There is a small subset, maybe 5% of people with epilepsy, who require a full surgical characterisation. And here we're looking to see if the person's epilepsy is focal, as I talked about before, coming from one part of the brain, and that part of the brain could be safely removed and cure the patient of their epilepsy. They may need long-term medication, but perhaps if they're on 4 medications, you might be able to, with time, take it down to 1 medication instead of 4 medications. Now, only a very small subset of the patients with epilepsy do require epilepsy surgery, but in the right patient, it can be a wonderful treatment and really change their lives. I don't think everybody with epilepsy is different to the next person. I think there are some very clear epilepsy syndromes we can diagnose, and if you know the right syndrome, for example, juvenile myoclonic epilepsy is a common adult epilepsy, that helps tell you which drugs are likely to work. It helps inform about prognosis. I think that every human being is different to every other human being, and from that point of view, there are all the other things that the patient brings to their table, their psychological status, their personality style, their intellect. So all of that makes everybody different and individual, but I don't think everyone's epilepsy is different to everyone else's. Yes, look, I think it's incredibly challenging treating people with epilepsy and doing it well as a doctor. And I think when people first face the diagnosis, they're in shock and their families are in shock and they see their whole life unravelling before their eyes. And we need to show them that this is not the case, that this is just an extra glitch, if you like, in their life, that they have to work out the right treatment. They then need to come to terms with the diagnosis, and this can be hard, particularly the adolescents. They don't want it. They want to be like everyone else and they want to throw it away and they won't take their medicine. So we have to try and help them to learn how important it is to become compliant with anti-epileptic medication and take it reliably. And in a way, the patient needs to start owning their epilepsy and therefore managing their own condition. I see my role as a doctor as being their advocate, their support person, but I can't be there twice a day, every day to make sure they have their medicine, to make sure they get enough sleep, to make sure that they avoid things that might trigger their seizures. So, you know, almost everybody with epilepsy is more likely to have a seizure if they're tired or stressed. Many people are more likely if they're unwell. So they have to learn a bit about how to manage their lifestyle and to take their epilepsy seriously. I think epilepsy does carry lots of implications for lifestyle, and I think once you have epilepsy you need to adopt a more routine in your lifestyle, if you like. You need to ensure you get enough sleep, and again this is an issue often for adolescents who want to go out and party all night. So I tell my adolescents, see if you can have an afternoon nap. And then you have a bit of credit on your sleep and maybe not get so tired. You need to make sure you have your medication pretty reliably on time. Now that doesn't have to be to the minute. But, breakfast and dinner is a good time to have twice a day medication, and you need to make sure that you don't miss it. If you sleep in, you need to know what to do. So say you're meant to have your medicine at 8 o'clock and you sleep in and it's noon, well then I would have your 8 o'clock medicine at noon and move your dinner medicine a bit later in the day. So there are ways you can do to try and make sure that you have the best routine you can have with your epilepsy. I think we know that, too much alcohol can cause seizures in people. So we have to be aware that if you've got epilepsy, you're obviously more likely to have a seizure if you get drunk. So getting drunk is not good. What I do tell my adult patients is that they can have 1 or 2 glasses of alcohol a night. Obviously, if they're very strong drinks, I wouldn't recommend 2 glasses, maybe 1 at most. But in general, a lot of the anti-epileptic drugs suggest you shouldn't have alcohol with them. And I think one has to be very cautious. So I'd be drinking much less alcohol probably and be very cautious about it. I don't think it means you can't have it all together though. Well, I don't think a very warm environment can cause seizures. I think a warm environment does make one more prone to fainting. And all of us can faint and have a seizure within a faint, which we call convulsive syncope. So if it's a really hot day and you haven't eaten and you're very worried and you might be standing in the sun like the soldiers on duty waiting for the Queen to walk up and down, then often you'll see soldiers will faint and then they might have a convulsion within the faint, and that all relates to lack of oxygen to the brain. But that's not the same as epilepsy being caused by it being a hot day. I don't think that's the case. Now, some of the children I look after are prone to seizures with fever, and lots of people are prone to seizures if they're unwell. So that's an internal body fever, and that can make you prone to a seizure in some individuals. Some people with epilepsy never have a seizure with fever. When you have an EEG, they will always do photosensitive testing, which is where they do the flashing light at different frequencies to see whether you do show abnormal electrical activity in your brain triggered by the flashing light. Now, about 8% of people show photosensitivity, which is the photic stimulation causing epileptic activity. Not all of those 8% have epilepsy. So in fact, people often worry about photosensitivity a whole lot more than they need to. There are specific epilepsy syndromes that are prone to photosensitivity. The commonest would be juvenile myoclonic epilepsy, which begins in adolescence and usually continues into adult life. They're prone to convulsive seizures and they have these little jerks. Now, many of the patients with that specific syndrome have photosensitivity, and if you do have photosensitivity, then you have to be careful where there is a strobe light, or perhaps if you're driving along and the sun's flicking through the trees, that's a photic stimulation, a form of photic stimulation. Sometimes computers or screens can be, but often these days they're not with the new technology. Many people don't like the flashing lights which are shown during the EEG study, and they're worried that they are photosensitive. Most of these people are not actually photosensitive. Photosensitivity refers to where you have seizures triggered by flashing lights as stimulation. This is why we do flashing lights during the EEG, to try and trigger an epileptic abnormality during the recording. It is hard for you to predict yourself if you are photosensitive, and it is something you should discuss with your doctor. The first aid management of seizures very much depends on the type of seizure that the patient is experiencing. So if the person is just stop and stare and not moving around, you don't need to do anything except stay by them, tell them afterwards you've had a seizure, you know, what day of the week it is, what time it is, where they are, and just check that they're reoriented. On the other hand, if they start to have a staring spell and they're holding a pair of scissors or a hot cup of coffee, you might just gently take them out of their hands so that they don't hurt themselves. Sometimes in the focal seizures or the staring spells, people might start walking around. And again, then you would have to ensure they were safe and didn't walk across the road, or you'd just stay with them and make sure they were safe. If If a patient has a convulsive seizure where they fall to the ground, then they're much more at risk of hurting themselves. They can sustain a head injury from falling to the ground or from hitting something as they fall. So if you see a patient go into a seizure and you think that they might then go into a convulsion, you would go as close as you could to them and you would hold on to them and check you caught them if they fell. Once they're on the ground, then you just need to make sure that they're not hurting themselves if they're hitting something. And once the seizure is over, you would put them in the coma position on their side. You don't try and do that with a big person during a seizure because they're too heavy and you could hurt yourself. But with a child, you would put them on their side from the start. The other very important point is you don't put anything in their mouth. This is an old wives' tale about swallowing your tongue. It's just not true. And people have put things in people's mouths, such as their finger, and had their fingers bitten off. So you definitely do not do that, and no spoon in the mouth. If you put the person on their side in the coma position, then their jaw will fall forward and their tongue will fall forward. And their tongue is a huge muscle at the back of the throat. If you're flying flat on your back, the tongue can obstruct the airway. If you put someone on their side, it will fall forward and not obstruct their airway. And once the seizure's finished, you can clean out their mouth with your hand and get rid of any saliva or vomit if it's come, which they would be at risk of inhaling. But you don't do that till the stiffening and jerking has finished, or you might hurt yourself.
Indeed.
The other important point with the seizure is to consider calling an ambulance. So if you know the person very well who's having the seizure, and the seizure always lasts 1 or 2 minutes, you'd look at your watch at the beginning of the seizure if you have the wherewithal, and maybe say the time out loud so you remember. And then if the seizure goes longer than their usual seizure, say their usual seizure was 2 minutes and it got to 2 minutes and they weren't slowing down, it wasn't ending, then you'd be on the phone to the ambulance, to 000 saying, I need an ambulance. If, on the other hand, you know the patient very well, you've seen a few seizures, you know they last this long, after 2 minutes it's finishing, you just stay with them, make sure they were okay, that they came to, and they were oriented and safe to be on their own. So it depends a lot. If you don't know the person at all, it's very scary seeing a seizure and you might call an ambulance immediately. Education, education, education. We need a lot more resources to educate people about epilepsy. Epilepsy has very sadly had a stigma for a long time, and I think that's improving, but it only improves with education. And we need to get out there, tell people about epilepsy. It's very good when people with epilepsy tell people about their epilepsy because it helps everyone else to own it more, and also to see how normal you can be with epilepsy and how normally functioning and high functioning. I think the more people understand and know someone with epilepsy, the better they cope, the more interested they are, and the more we can change the outcomes and help everyone support a person who has seizures. And this education needs to be online, it needs to be in lectures, in pamphlets, in storybooks for children, all sorts of ways. And I think that the lay bodies do a brilliant job at this, but we need more. We need more and more education because it's got a long way to go still. I'm passionate about my research and I'm really excited because I can see it's making a difference to the patients that I look after and their families, and that makes it very meaningful. The other reason I'm passionate about my research is I know it can help people all over the world, and I've seen that. It's happening all the time, and that's really exciting to know that my work in science, with my team I should add, and my collaborators, and we have a fantastic group here at the University of Melbourne and the Florey, but also we have many collaborators all over the world and in other parts of Australia such as Adelaide, where they help us and work with us on the research. Now, this research at a scientific level is very satisfying too, because it helps us get to the biology, the actual mechanisms of why seizures occur. And if you can get to the real essence of the cause, that's the beginning of trying to find new treatments and targeted treatments, which are much more likely to make a difference. So the research has many areas that I enjoy about it. One is understanding the biology, but by far the most important one for me is making a difference to my patients and their families. Now, my research area is in genetics of epilepsy. Together with our collaborators, we found the first gene for epilepsy in 1995, and now we've found more than half of the genes known. But this list is now rapidly exploding because it's a very exciting time in molecular neuroscience, which means finding genes. Yes. And lots of new genes have been found, and we've been involved with finding quite a few new genes in the last year with collaborators in America and in Belgium and in Australia. Now, each gene in its own is a whole story, and I always think that finding the gene is just the beginning, because once you find a gene, you work out what protein that gene makes, and then you have to find out, when they have a genetic abnormality, what's gone wrong with that protein, how is it not working properly. And then when you can figure out how it's not working properly, you then introduce that protein into a Petri dish or into an animal model, such as a mouse or a rat. And then you figure out, does that mouse or rat have seizures? And then you can go from there to trying to figure out new treatments. Now, I don't do any of that. That's all done by very clever laboratory scientists, physiologists, molecular geneticists, really amazing minds, and they figure out new treatments with us. But my role then is to translate it back and to try and help the patients. So they might find something that works very well in the Petri dish on this abnormal protein, and then we might say, well, can we use that same substance in human beings? Would it be safe? Can we do trials? And can we change the outcome? The other important point is that it might improve the outcome not just of seizures, but of development of other consequences. And we haven't really touched on that. In many of the severe epilepsies, you can have developmental delay or severe intellectual disability in the children or adults with these conditions. Associated with that are other comorbidities, so issues like depression, autism spectrum disorders, schizophrenia sometimes, other disorders due to the same genetic change. If you're talking about dementia that we see in older adults, a very small proportion may have seizures, but there isn't really a strong correlation between dementia and epilepsies. On the other hand, if you're talking about loss of cognition or cognitive decline, that certainly happens in many of the severe children and adolescents I see who have very severe epilepsies, or epileptic encephalopathies we call them, so disorders of the brain with ongoing frequent epileptic activity, and that, if you like, keeps pummeling the brain and they can't learn and they might go backwards. So that sort of cognitive decline or dementia does occur with the severe epilepsies. But if you're talking more about the other end of life with Alzheimer's and late onset dementias, there's a slight increase in epilepsy, but not much. The big picture of our genetics, just to go back to the basics, is that our bodies are made up of billions of cells, and they all have our genes in them, and these are on our chromosomes. So you probably know about the 23 pairs of chromosomes, pairs number 1 to 22, and then the sex chromosomes, which are XX for a girl and XY for a boy. On those 23 pairs of chromosomes, you have 25,000 genes. Of those 25,000 genes, many have, say, 5,000 parts. So when we're talking about a genetic abnormality that can cause epilepsy, it might be one of those 5,000 parts of one of those 25,000 genes. So I say it's a bit like looking for an abnormal brick in Melbourne. And that's what we're doing. So in terms of genes, everyone has the genes, but we don't all have the abnormality of the genes. We all have abnormal genes. 1 in 500 genes is abnormal in all of us. But the question of whether you have a gene that causes epilepsy, that's what our research is doing. And at the moment we know probably it's really rapidly changing, but probably around 40 genes for epilepsy. We're looking to identify more genes, but I don't think it's going to be like breast cancer. I think there are going to be many more genes and many more disorders, so much more mixed. And I'm not sure that you'll be born. Maybe one day you will be born and you'll have your genes tested, but in terms of understanding what the variants are that are found in your genes or your genome, I think we're a long way from being able to interpret all of that yet. I'm sure one day it will come, but it's a fair way off. some medications work well for some epilepsy syndromes, let alone people. So let's just first talk about the type of epilepsy. So we try and diagnose an epilepsy syndrome, and that will actually tell us which drugs are most likely to work. And we know that some drugs might work really well for one syndrome, but some drugs might actually make those people worse. So that's why the neurologist or paediatrician needs to know which ones to choose for the specific syndrome. And that's why finding an epilepsy syndrome diagnosis is very helpful, because it guides your treatment. So in addition to treating the specific type of epilepsy syndrome, the person brings their own self to the table, and they may be prone to particular side effects such as depression or such as kidney stones, and that obviously affects which drug you may elect to give them. You may choose a drug that's less likely to give you depression or less likely to give you kidney stones. It's important to remember with any anti-epileptic therapy that most of the side effects only occur in a small proportion of patients. So most side effects occur in far fewer than 10% of people, and therefore, although we have to tell the patients about the potential side effects, it's important to get the perspective that the epilepsy is a condition they're dealing with now. The side effects may occur, but are much more likely not to occur. There's some exciting work by Professor Mark Cook at the University of Melbourne and St Vincent's Hospital looking at prediction of seizures. And earlier this year, he, together with my colleague Professor Sam Berkovic and Professor Terry O'Brien, published a paper where they implanted patients with focal epilepsies and recorded what was happening, and showed that this specific device could predict when a seizure was likely to occur. Now that's really the first time that's happened, a very exciting finding, and they're looking at the next stages of that. But you can imagine this person has a device and it says red, you're about to have a seizure. They can have some medicine to try and prevent a seizure. Blue, you're not about to have a seizure, go and have a good day and don't have to worry too much. So the idea of seizure prediction is fantastic. Is it out there clinically in the world? Not yet, but hopefully in the next few years it will become. It's still got a bit of a way to go. I wanted to be a paediatrician, and then I wanted to be a paediatric neurologist, and then I trained in that in London at Great Ormond Street. But then I came back and started my PhD with Professor Sam Berkovic, and that's really where I got interested in epilepsy. And epilepsy is one of those areas, the more you know, the better it gets. It's more and more fascinating, and the more you realise we have to understand, and the more we can make a difference to our patients and their families. The issue of your child having epilepsy is often not something the younger adult thinks about. And then when they're thinking about pregnancy, they suddenly think, will my child be at risk of having seizures? The overall answer is that the risk is only very slightly increased. So the frequency of epilepsy in the general population is 2 to 3%. If you're a woman with epilepsy, your child has overall an 8% risk of having epilepsy. But this is not equal across all types of epilepsy, and it depends on the type of epilepsy that the woman has, and that will determine the risk to her child. Now, mostly we don't know the genes in most people with epilepsy, but if you're in that situation where we do know your gene, then you can get much more accurate genetic counselling about the risk to your child. And for that, we would normally refer you to a clinical geneticist who is a medical specialist who specialises in discussing risks with you and the risk of you having a child with epilepsy. And they will usually do that to both parents together and discuss the whole situation, so that you go into a pregnancy informed about the recurrence risk of epilepsy in offspring. I like the people the most, I think. I really appreciate how special so many of the families that I look after are. I like the people I work with. I have fantastic team members and collaborators. I like the intellectual exercise that we go through in firstly diagnosing a patient, trying to figure out, is it epilepsy, is it not epilepsy? If it is epilepsy, what type of epilepsy? I like seeing the difference I can make to people's lives. And I like communication. I like writing papers with my colleagues. There's so much about what I do that I really enjoy. I like growing young people, mentoring. I do a lot of mentoring, lots of PhD students, lots of fellows from all over the world. I feel very privileged with my career. It's very exciting and fulfilling.